Chapter 6, Restraints. 1.0 Introduction. Restraining patients is a challenge because it has legal implications on the healthcare facility and the patient. The presence of a qualified healthcare professional is therefore considered necessary. Restraints prevent harm and can assist in the implementation of treatment. Guidelines and policies on restraints are provided by regulatory bodies to ensure that the restraint is only carried out when necessary and does not cause danger to the patient. This chapter discusses restraining techniques and appropriate use of chemical restraints. Emphasis is placed on a restraint-free environment. 2.0 Restraining techniques. Agitated patients can be a threat to others and to self. The terms used in most mental health units are danger to self, DTS, or danger to others, DTO. Restraining entails restricting the arms, legs and strapping down the waist to reduce or contain mobility. Patients can be confined in the hospital willingly or unwillingly. Restraint prevents a patient from moving their head, body, arms or legs freely. Items used to facilitate medical examination such as bandage are not considered restraints. A. Least restrictive measures. Measures to restrain patients with assaultive behavior are carefully selected because restriction or seclusion could lead to negative outcomes if inappropriately implemented. Therefore, recommended measures should be least restrictive and steered towards specific results. Restraining techniques are recommended only when necessary. A patient can only be restrained following a physician's order. In certain cases, the registered nurse could start an emergency restraint, but must obtain a physician's order within few hours. Order includes the length of time the assaultive person should be restrained. Healthcare professionals should be aware of the body alignment when implementing least restriction to avoid body injuries. The patient should be able to change movement and exercise joints a bit. Body circulation is important to enable the body to continue functioning as Ballard and Rocket, 2009, p. 34, point out. B. Psychological restraint. Psychological restraint may precede chemical restraint and physical measures to restrain. Psychological restraint is given in the form of a program or a therapy. Activities are designed to meet the diverse situation of the assaultive behavior by withholding certain privileges. The privileges withdrawn do not include the basic needs. The patient being restrained will have access to shelter, clothing and food. Patients undergoing psychological restraint can interact with family, healthcare professionals and attorney. Psychological restraining is part of treatment which can be prescribed as a therapy. C. Seclusion and exclusion. Seclusion implies that a patient is placed in a separate area from others where the room is locked. When a patient asks to have own room that is open, it is not seclusion. A patient is not in seclusion if they are locked in a room because there is a quarantine to prevent spread of disease. The room where an aggressive patient is secluded is not locked if the patient is a child. The room is often watched and secured. Safe and soft items are available for the aggressive patients to vent. Mittens are applied to prevent pulling of fore lines, etc. The objective of putting an aggressive patient in seclusion is not to cause harm, but to prevent the patient from becoming aggressive, thereby reducing factors that encourage violence, as Lewis and Ford, 2000, p. 34, discuss. Seclusion is given after the least restrictive policies have not been effective. Exclusion takes place when a patient is moved from one place to another restricted area. Patients with mental disorders who persistently do not cooperate with management intervention may be excluded from the other patients with mental disorders. Exclusion is different from seclusion because in exclusion the room is not locked, while in seclusion the room is locked. Rooms for patients in exclusion are constantly monitored to ensure safety. D. Mechanical restraint and 4-point restraint. There are situations when the aggressive patient has acute violent behavior. The healthcare professional designs a mechanical restraint plan recognizing the imminent danger to self and others. The plan indicates how the restraint is to be carried out. Straps, mittens, wristlets, anklets, lockable buckles, vest strap, etc. are used. The patient may be allowed certain movements at specified intervals. Mechanical restraint should be applied carefully to avoid harm and removed safely. Park et al., 2007, p. 13. When the de-escalating measures fail, measures could be put in place to reduce the chances of hurting the patient and healthcare professional while attempting to restrain them. 4-point restraints can be applied in the inpatient facility or the emergency room. The healthcare provider should ensure adequate documentation of continuous monitoring. E. Restraining procedure. Restraining a patient requires preparation to avoid incidents or injury. Healthcare providers with assaultive behavior management training should be prepared for emergencies and be willing to assist if required. Before attempting to restrain, Obtain resources and the required number of people. Get the room ready before the patient is placed in seclusion or exclusion. Ask people by name to give a hand and inform them about the situation. Make a plan on how to approach the patient by assigning specific tasks to everyone. Reach the patient systematically and commit to play own part. Appoint a leader who will give instructions when there is need to change the plan. The leader will assess the situation and make notes of the progress. Make an alternative plan in case events do not turn out as expected. The plan will entail a signal that there is success and a signal that there is failure. The leader will notify the team when efforts are fruitless and they should stop. 3.0 Appropriate use of medications as chemical restraints. Chemical restraints are used to control behavior by administering medication. The medication is given according to individuals' needs. The medication given to violent patients is short-term and is administered depending on the patient's history and circumstances. It is given on emergency to control behavior and to facilitate treatment. Moore 2010. p. 5. F. Medication categories. Chlorpromazine is a medication that was used to sedate aggressive patients. However, chlorpromazine's usefulness has been exceeded by adverse effects on tolerance, hence its use has been discontinued. Butyrophenones have been prescribed as an effective and safe medication for use in containing violent patients. Butyrophenones have been successfully used together with benzodiazepines to restrain the assaultive behavior patient. I. Butyrophenones. Tropridol and haloperidol are butyrophenones, which are also neuroleptics. Tropridol is appropriate for agitation which causes sedation. Tropridol is a first-line medication. Haloperidol is a tranquilizer for calming patients with violence. The medication is given in the form of injection. Tropridol and haloperidol are safe to use for those with substance abuse or overdose, but will require monitoring. Butyrophenones are also known as typical antipsychotics. 2. Benzodiazepines. Benzodiazepines in the form of lorazepam and midazolam can also be used to cause tranquilization effects. Lorazepam is considered the best because of its short half-life, rapidness, and active metabolites and effectiveness. Midazolam effects take a shorter time than lorazepam, but is fast in effect and safe. Benzodiazepines are specifically recommended for patients with intoxication. Assaultive patients can be given benzodiazepines for control successfully. 3. Benzodiazepines and butyrophenones. A combination of benzodiazepines and butyrophenones gives superior effects than if used alone. One of the successful combinations is haloperidol and lorazepam. G. 8 typical antipsychotics. Risperidone, ziprasidone and olanzapine are in the category of atypical antipsychotics. The medication is a recent development that corrects the negative effects of extrapyramidal symptoms. The medications have improved outcomes when compared with butyrophenones. Atypical antipsychotics are tolerable by different groups of patients. The medication is specifically effective on patients with mental disorders in the short-term treatment. H. Effects of chemical restraints. Chemical restraints may have effects such as depression of respiration and will require monitoring and proper adherence to policies to ensure safety. The chemical restraint is prescribed by the physician. Assessment is done on the patient's response on vital body organs and body response to the treatment. Healthcare professionals should follow the recommended dosage according to the age of the agitated patient. Medication on pregnant and lactating mothers should be avoided if possible. Physical restraint is not recommended for pregnant women because of injury to the spine when in the second and third trimester, hence chemical restraints are recommended. Neuroleptics should not be given to women who are pregnant or nursing. Medication should be discontinued if it causes negative effects, allergy, on the patient. Patients with intoxication should not be given neuroleptics, since it could cause seizures. Additional concern emerges since the medication could expose the fetus to abnormalities in development. Pregnant women are likely to develop respiratory issues. The fetus could have poor brain growth. Because there is no certainty if the chemical restraint could cause harm to the fetus, it is advisable to use minimal dosage. I. Administrations of chemical restraints. The effect of chemical restraint is rapid and there seems to be reduced side effects. Giving the medication orally is preferred to intramuscular administration. Intramuscular administration is preferred if the patient does not cooperate and if there is imminent danger. Patients offered oral medication before intramuscular injection tend to trust the healthcare professionals, which enable the delivery of efficient service. This is because the patient gains an internal form of control as opposed to external control from the healthcare professional. Dissolving formulas and oral concentrated are preferred to the tablets. Tablets are discouraged because patients can hide them in the mouth and fail to swallow. In mental health, it is called checking medications. J. Implications of chemical restraint. Legal implications should be considered when a patient is restrained. Healthcare professionals would have to make professional judgment before choosing the chemical restraint because the patient has a right to and can make a complaint. The healthcare professional should obtain an informed consent from the patient and explain the treatment if they are of sound mind. The patient can reject or accept medication for restraint if they understand the course of treatment. If the patient is incompetent and poses immediate danger, the healthcare professional can proceed with chemical restraints without consent. A restraint-free environment is emphasized to prevent the negative effects of restraint. Patients under restraint have been found to suffer injuries from falls, broken bones, impaired circulation, incontinence, social isolation and depression. 4.0 Conclusion: restraining is done to prevent harm on patient and others. It sometimes enables healthcare professionals treat and control behavior of patient. Restraining techniques often implemented consist of least restrictive measures, psychological, seclusion and exclusion, mechanical and 4-point restraint. The strategies protect the rights of patients and are based on individual needs. Restraining is recommended and implemented by healthcare providers who monitor the progress and give recommendation. Restraints are administered and removed safely by trained healthcare professionals. Regulatory bodies recommend less restraining procedures, time limits and keeping of a record. Chemical restraints are used if other restraining techniques prove futile. Medications that are used include benzodiazepines, lorazepam, midazolam, butyrophenones, tropridol, haloperidol, and atypical antipsychotics, ziprasidone, risperidone, olanzapine. The medications sedate the patient to control behavior. Although the chemical restraints are safe to use, they can cause effects such as depression, hyperthermia, mental conditions, and rigid muscles or affect vital organs, hence the patient should be monitored. Chemical restraints are best administered in the form of dissolving formulas and oral concentrated or intramuscular or intravenous injection. The healthcare professional should be aware of the legal implications to avoid pitfalls. A restraint-free environment is suggested since it limits the number of injuries and other disadvantages associated with restraints.